Good afternoon, everyone. My name is Taslim Hassan, and I'm going to be presenting on COVID-19 and pregnancy, specifically focusing on the consequences for maternal health.
I'm pregnant. I'm scared. I don't have any idea what's going to happen. I am 34 weeks pregnant, exactly today. I have been diagnosed through clinical observation with having coronavirus. I woke up with this cough, which turned into a massive coughing fit, which left me unable to catch my breath, which caused involuntary tears to stream down my face and genuinely horrified my onlooking family. It felt like I was drowning. I was saying to my husband, it was like my throat was too narrow and I just couldn't get enough air in. And I was
The World Health Organization declared a global pandemic of COVID-19 caused by the SARS-CoV-2 virus in March 2020. The current coronavirus disease pandemic has become a major global health threat. Since its first identification in Wuhan, China in December 2019, COVID-19 has spread globally at an accelerated rate with rapid increases in cases and mortality. Today, the total number of COVID-19 cases identified in South Africa is over 1.4 million. Pregnant women are considered to be a high-risk group for SARS-CoV-2 infection, and the potential adverse effects of the virus on maternal and perinatal outcomes are of great concern. To date, there have been two periods of increased transmission, the first wave from week 24 to 28 of 2020 and the second wave from week 47 to week 1 of 2021. Unfortunately, the new COVID variant is 50% more transmissible than the previous variant of COVID-19. As explained in this graph, it took 107 days during the first wave for the Western Cape to reach its first 100,000 cases, whereas it only took 54 days for the province to get to the same number of cases during the second wave. So what do we know about the SARS-CoV-2 virus? COVID-19 is a capsulated single-stranded RNA virus. COVID-19 infection can result in mild disease in which the virus is cleared effectively by the immune system or severe disease with high mortality rates. To understand the COVID-19 phenotype during pregnancy, it is important to understand the pathophysiology and molecular mechanisms of COVID-19 and examine these in the context of the modulated maternal immune response. SARS-CoV-2 enters the cell via the angiotensin-converting enzyme 2, which is the ACE2 receptor, which is upregulated in normal pregnancy. Upregulation of ACE2 mediates conversion of angiotensin 2 to angiotensin 1 to 7. Despite upregulation of other components of the renin-angiotensin-aldosterone system, as a result of the higher ACE2 expression, pregnant women may be at elevated risk for complications from SARS-CoV-2 infection. Upon binding to ACE2, SARS-CoV-2 causes its downregulation, thus lowering angiotensin levels, which can mimic or worsen the vasoconstriction, inflammation, and procoagulopathic effects that occur in preeclampsia. Upregulated ACE2 in pregnancy is a possible risk factor for SARS-CoV-2 infection and subsequent preeclampsia development. The inflammation caused by SARS-CoV-2 may also result in a cytokine storm that can lead to multi-system organ failure. This excessive inflammation is thought to be the cause of severe COVID-19 and is associated with high morbidity and mortality. Physiological changes during pregnancy, such as reduced functional residual capacity, diaphragmatic elevation, and edema of the respiratory tract mucosa, as well as changes in cell immunity, can lead to increased susceptibility to viral infections and can have worsened outcomes. What have we learned from past experiences with viral infections in pregnancy? As the number of confirmed cases increases, evidence on the transmission, incidence, and effect of SARS-CoV-2 infection in mothers remain limited. Viral pneumonia is one of the leading causes of pregnancy deaths worldwide. Evidence from other similar viral illnesses such as influenza A, which is H1N1, severe acute respiratory syndrome, and Middle East respiratory syndrome suggests that pregnant women are at a greater risk of severe maternal and neonatal morbidity and mortality. Some evidence suggests that the risk of critical illness may be greatest in the later stages of pregnancy. A systematic literature review examining the effects of H1N1 found H1N1 caused significantly more severe disease in pregnant women compared with age-matched non-pregnant controls. The review reported an 8% maternal mortality rate and a 30% preterm birth rate. Pregnancy was a risk factor for hospitalization, ICU admission, and death. Other coronaviruses, SARS and MERS, had significant adverse maternal outcomes with a 25% and 28% maternal mortality rate, respectively. So what do we know about the clinical presentation of COVID-19 in pregnancy? The pre-COVID-19 Living Systematic Review has so far included over 11,000 currently and recently pregnant women worldwide with suspected or confirmed COVID-19. The most common symptoms of COVID-19 in pregnant women were fever and a dry cough. Less frequent symptoms were shortness of breath, myalgia, loss of sense of taste, and diarrhea, each present in more than 10% of women. Chest X-rays may be normal in early or mild disease. In a systematic review of pregnant patients diagnosed with COVID-19, the most frequently encountered findings were ground glass opacities, posterior lung involvement, multilobular involvement, bilateral lung involvement, and peripheral distribution and consolidation. Mild disease is defined as a woman with no clinical features suggestive of moderate or severe disease, with no symptoms or mild upper respiratory tract symptoms, without shortness of breath or reduction in oxygen saturation. Moderate illness is any woman that is stable, presenting with respiratory or systemic symptoms or signs, that is able to maintain oxygen saturation above 92% with up to 4 liters a minute of oxygen via nasal prongs, with a temperature above 38 or persistent cough, and clinical or radiological signs of lung involvement. Severe illness is any woman meeting any of the following criteria with a respiratory rate of more than 30 breaths per minute or an oxygen saturation less than 92% at a resting state or a PF ratio of less than 300. Critical illness is any woman presenting in respiratory failure with a saturation of less than 90% on oxygen therapy, severe respiratory failure with a PF ratio of less than 200, acute respiratory distress or acute respiratory distress syndrome, which includes patients deteriorating despite advanced forms of respiratory support, which is non-invasive ventilation or high-flow nasal oxygen, or patients requiring mechanical ventilation, or any woman on mechanical ventilation or other signs of significant deterioration, for example, hypotension, shock, impaired level of consciousness, or other organ failure. What are the risk factors for critical illness in pregnancy? This study illustrated that 1 in 10 pregnant women admitted to a hospital in the UK with SARS-CoV-2 infection needed respiratory support in a critical care setting, and 1 in 100 patients died. 70% were overweight or obese, 40% were aged 35 or over, and a third had pre-existing comorbidities. More than half of all women admitted with SARS-CoV-2 infection had given birth at the time of the analysis. 12% were delivered preterm solely because of maternal respiratory compromise. Almost 60% of women gave birth by caesarean section. Most caesarean births were for indications other than maternal compromise. Risk factors that appear to be associated both with being infected and being admitted to hospital with COVID-19 include being overweight or obese, pre-existing diabetes and chronic hypertension, maternal age above 35, living in areas of increased socioeconomic deprivation. In addition to these, the risks of becoming infected with COVID-19 is more common in individuals who are more exposed by, for example, working in healthcare or other public-facing occupations. Both chronic hypertension and pre-existing diabetes were associated with maternal death in pregnant women with COVID-19, which are known risk factors in the general population. But it is not known if COVID-19 was the direct cause of death for these women. So how does SARS-CoV-2 impact pregnancy? There are many factors involved with evaluating the impact of SARS-CoV-19 on the pregnant woman. For example, what is the significance of asymptomatic disease, pneumonia and respiratory distress syndrome, the concern about breast milk transmission, placental infiltration and thromboembolic complications, the possibility of vertical transmission, coagulation with hypercoagulation, thrombi and emboli, cardiac strain, endothelial dysfunction, alterations in cell and antibody-mediated immune response, as well as increased anxiety and stress that has an effect on the adrenal axis. There is little evidence about the possible impact of COVID-19 in early pregnancy. Seasonal influenza has been associated with higher rates of miscarriage. Extrapolating from effects of other viruses in late pregnancy, greater than 24 weeks gestation, we can expect that COVID-19 infection could cause increased rates of adverse pregnancy outcomes, such as fetal growth restriction, preterm birth, and perinatal mortality. The largest cohort study to date from the United States includes population-level data from over 90,000 women, of which 8,000 were pregnant. Pregnancy was associated with significantly increased chance of hospitalization, ICU admission, and the need for mechanical ventilation. There was no significant reduction in mortality. In addition to the systemic immunological changes of pregnancy that have the potential to have an impact on lung function, anatomical changes are also present in the respiratory system. Physiological alterations to the chest shape and elevation of the diaphragm due to diaphragmatic splinting by the gravid uterus causes changes to the respiratory function. Although there is a 30 to 40% increase in tidal volume, the reduction in chest volume leads to a decrease in functional residual capacity, end expiratory volumes, and residual volumes from early in pregnancy. The reduction in total lung capacity and inability to clear secretions can make pregnant women more susceptible to severe respiratory infections. Myocardial injury and its complications, for example, cardiomyopathy, pericarditis, pericardial effusion, arrhythmia, and sudden cardiac death, were observed in 9% of patients who died in Italy up until the 13th of April 2020. Takotsubo syndrome, also caused by SARS-CoV-2, has also been described in some women. Another interesting finding is the high rate of postpartum hemorrhage and blood transfusions observed in pregnant women with COVID-19 infection, much higher than that reported in the general population of pregnant women. Hemostasis changes may occur in these women, especially as clinically significant coagulopathy with antiphospholipid antibodies has been reported in non-pregnant patients with COVID-19 pneumonia. Preeclampsia was reported to be associated with severe COVID-19 in small studies, but it requires further assessment as the clinical presentation of severe preeclampsia could mimic worsening COVID-19. Infection with SARS-CoV-2 is likely to be associated with an increased risk of maternal venous thromboembolism. Pregnancy is a hypercoagulable state with increased thrombin production and an increase in intravascular inflammation. During pregnancy, there are higher levels of circulating coagulation and fibrinolytic factors, such as plasmin, and these may be implicated in the pathogenesis of SARS-CoV-2 infection. Therefore, pregnant women with COVID-19 may have additive or synergistic risk factors for thrombosis. This hypothesis is supported by a case report describing mortality in a woman at 29 weeks gestation with COVID-19 due to a large pulmonary embolus. Current guidelines recommend that all pregnant women with confirmed COVID-19 infection should have thromboprophylaxis until 6 weeks postpartum with a low threshold for investigation of possible thromboembolism. Mortality in COVID-19 is predominantly due to acute respiratory distress syndrome. Emerging evidence suggests that pulmonary endothelial cell dysfunction has an important role in the onset and progression of ARDS. In ARDS, this endothelial barrier is damaged, leading to tissue edema, excessive inflammation, and hypercoagulability. Risk factors for COVID-19, that is, increasing age, obesity, diabetes, and cardiovascular disease, are all associated with endothelial cell dysfunction. Two Brazilian studies represent the only data from low and middle income settings. The first report on all female patients admitted to hospital with COVID-19 and found that 18% were pregnant, which is much higher than the pregnancy rate in the general population. The second study included almost 1,000 pregnant women reported with COVID-19 infection, with a mortality rate of 12%. This is likely to be an overestimate as only women with severe symptoms were tested. However, the authors raised concern that only 22% of the women who died were admitted to ICU, and only 64% of these women were ventilated, raising the possibility that much of the excess mortality is due to the inability to access critical care. There may be additional complications in this setting related to the higher rates of both malnutrition and TB among women of childbearing age, and it is unknown whether this will impact on COVID-19 infection. In resource-limited settings, pregnant women are particularly vulnerable to the adverse impact that COVID-19 has on health services at all levels. Concerns about overwhelming resource-constrained healthcare systems has led to a reduction or suspension of many reproductive healthcare services. Substantial alterations have been made to the running of routine sexual and reproductive health services, which may increase gender inequalities in health, economic well-being, and social status. This reduction in clinical services alongside supply chain and manufacturing problems may make contraception access difficult. These factors will also impede access to and provision of safe abortions. Regarding antenatal care, staff and equipment have been diverted to the provision of acute medical care, meaning clinical capacity is limited, reducing the ability to screen for conditions such as gestational diabetes. In many settings, policies on social distancing have necessitated the restructuring of healthcare services to reduce face-to-face contact between doctors and patients, making diagnosis and support of mental health conditions more challenging. During this pandemic, many women are more vulnerable to intimate partner violence and associated adverse pregnancy outcomes, and they are less able to seek support. Increased stress and anxiety during pregnancy upregulate inflammatory pathways and correlate strongly with neuropsychiatric disease of the offspring. The pandemic is already widening social inequalities and the likely impending economic crisis, increasing inequality and pushing more women into poverty. Socioeconomic deprivation is a clear driver of maternal morbidity and mortality, and a positive gradient has been observed between deprivation indicators and a range of adverse maternal child health outcomes. We can expect the downstream effects of COVID-19 to be apparent for a number of years. This pandemic has resulted in an increased level of anxiety and other mental health problems in the general population, which has a larger impact on women than on men. There is increasing evidence that this is likely to be even greater for pregnant women, as pregnancy represents a period of additional uncertainty. Specifically, these anxieties are likely to revolve around COVID-19 itself, the impact of social isolation resulting in reduced support from wider family and friends, the potential of reduced household finances, and going through the process of childbirth alone. So what do we know about the timing of delivery in COVID-positive pregnant patients? The current data suggests that asymptomatic or mildly symptomatic patients positive with COVID-19 who have no medical or obstetric indications for urgent delivery should not be delivered. For most patients below 39 weeks with COVID-19 and mild illness who also have medical or obstetric complications, for example, pre-labor rupture of membranes or preeclampsia, the timing of delivery is generally determined by usual protocols for the specific medical or obstetric disorder. For patients with severe illness, there are multiple issues to consider and timing of delivery needs to be individualized. Pregnant women have a worse prognosis and higher mortality rate. Therefore, early delivery or termination of pregnancy should be considered in certain scenarios. For example, with rapid maternal deterioration, multi-organ failure, failure to maintain adequate PO2, fetal compromise, difficult mechanical ventilation, and other obstetric complications. Increased oxygen consumption and reduced functional residual capacity, which are normal in pregnancy, may facilitate maternal deterioration in patients with pneumonia. Excessive uterine distension from multiple gestation or severe polyhydramnios in the third trimester may further compromise pulmonary function. These patients should be individualized. Let's look at the morbidity and mortality at Tygerberg Hospital during the first coronavirus wave. During the first COVID-19 wave, 21 pregnant women were seen with critical disease. The major risk factors identified were obesity or overweight, pre-existing hypertension, or diabetes. The major clinical presentations were fever, dry cough, and shortness of breath. 18 patients were admitted to high care and ICU, of which 15 patients developed respiratory failure and 12 patients went on to develop ARDS. 6 patients required invasive ventilation, and 9 patients went into cardiac arrest with maternal demise. 5 patients developed acute renal failure, 1 patient with cardiomyopathy, and 7 patients developed preeclampsia. Lastly, let's talk a little bit about the vaccines that are available to us. Dr. Anthony Fauci, a leading infectious disease expert, said that about 10,000 pregnant women in the US have been vaccinated since the FDA authorized 2 vaccines, and so far there have been no red flags. But the WHO updated recommendation seems to contradict this statement. WHO guidelines advise that pregnant women may be vaccinated only if they are at high risk of exposure to the coronavirus, such as women in healthcare or underlying medical conditions that put them at risk for severe disease. ACOG recommends that COVID-19 vaccines should not be withheld from pregnant individuals who meet the criteria for vaccination. Until findings are available from clinical trials and additional studies, only limited data are available on the safety of COVID-19 vaccinations, including mRNA vaccines administered during pregnancy. Limited data are currently available from animal developmental and reproductive toxicity studies. No safety concerns were demonstrated in rats that received the Moderna COVID-19 vaccine before or during pregnancy. Studies of the Pfizer vaccine are still ongoing. The development and use of mRNA vaccines is relatively new. These vaccines consist of messenger RNA encapsulated by a lipid nanoparticle for delivery into the host cells. These vaccines utilize the body's own cells to generate the coronavirus spike protein, which, similar to other vaccines, stimulates immune cells to create antibodies against the COVID-19 virus. The mRNA viruses are not live virus vaccines, nor do they use adjuvants to enhance vaccine efficacy. These vaccines do not enter the nucleus and do not alter human DNA in vaccine recipients. As a result, mRNA vaccines cannot cause any genetic changes. Thank you for bearing with me and listening to my talk.